Hello, hi guys, it's Bundenge say here. Bona, today, remove Tilo Private Hospital, Rotobana, gynecologist. Today, Rotsara topic is important too much, especially Mobatung Babume. Robuaka, hormonal changes, and menopause. For you to know more, stick around. This is Connekt Media. Arba Dumbele. Hello, hi guys, it's Bundenge say here. This is Connekt Media. Today, Remobotilo Private Hospital, Richitile doctor, you know, Wabana tall, dark, and handsome, but he's not that dark, you know. Richitilian. Ladies, today, we are here. Let me not waste time. Let me welcome our doctor. Doctor, how are you?
You're fine, thank you. And you?
No, I'm good, doctor. Today, we're going to chill with you, and I believe that we're going to have so much fun.
Yes, I do.
All right. Can you please introduce yourself to our viewers? Tell them who are we chilling with this evening.
Okay. I'm Dr. Kalenga Moya Martino. I studied at Medusa as undergrad, and then postgrad also I went back to Medusa. After undergrad, I went to Uppington for internship. After internship, I went to Mpumalanga, where I stayed for 4 years in a small hospital, Multimedia hospital. I stayed for 4 years. And thereafter, I went back to Medusa to specialize in obstetrics and gynecology, which I completed in 2014. And then that was exactly the year when Buchilo was open. Then I came here. Since then, I've been practicing at Buchilo Private Hospital as a specialist in obstetrics and gynecology. Yeah.
Yeah, no, doctor, you're speaking so fast and you said something important and I missed it. What exactly do you specialize on?
My specialty deals with women and their health-related problems. We look after women when they are pregnant, and women when they are not pregnant, when they are experiencing their woman-related problems. That's what we call obstetrics and gynecology. That's what I do.
Okay, doctor. You could have chosen anything. You could have been a lawyer, soccer player, you know. Why did you choose this profession?
Truly speaking, I don't know. But as early as primary school, I knew I was going to become a doctor. For which reason, I don't know. And as I was growing up, I started catching insects, the grasshoppers, operating on them, and they were dying. It was really...
It was painful.
Yeah, it was paining me. But I kept on trying, but I never succeeded. And then eventually, as we were growing up, later on, I realized I got to know that I have relatives, cousin brothers who are doctors. Then, as I was interacting with them, it became more fascinating. Later on, the ideas of becoming pilots came into play, but that of being a doctor prevailed, and here we are today. I don't regret it.
I think I understand. It runs in the family.
Yeah, but I didn't even know that I had cousin brothers who were doctors.
Oh.
I was very young. I didn't know them, but in my head already that seed was planted. By who? I don't know. God knows.
It's in the genes.
Yeah, maybe.
Yeah, because you fell in love with it at an early age.
Yeah.
So far, are you enjoying what you're doing?
Yeah, very much so.
What makes you enjoy your job, doctor?
Medicine is very fascinating, even more for obs and gyn.
Yeah.
Obs and gyn, we come to see the life as it brought into being from virtually like nothing. From conception, you look at after the embryo, eventually the fetus, you deliver that baby, you hand over to the mother to see the joy on the face of that couple. It's really rewarding and very enticing, really. It brings joy in my life,
Okay, so today we'll be talking about hormonal changes and menopause. I want you to educate us more about that, because for us as men, it's difficult because we don't understand these things. And I believe there are women out there who doesn't even understand it, whereas those things are happening to them. You know, so can you take us through the menopause? What is happening? What is menopause actually?
Okay. By definition, menopause is actually it's an event.
Okay.
It's not a process.
Okay.
It refers to the last menstrual period. When a person has a period for the last time, and for the 12 consecutive months she does not see the period, then we would say that she is menopausal. She has ceased to menstruate. It must last 1 year of not having period, referring to that last period. Meno, meaning menses, pause, stop. It refers to that moment where the period stops. But then it continues. We say the person is menopausal when she has stopped for at least 1 year, and throughout that time we will call that she has menopause. Yeah. Now, to try and understand what is menopause and what brought it about, it's important we go back to menstruation. To understand first menstruation. What is menstruation? How does menstruation come about? Menstruation starts from the head. You will be surprised. It starts from the head. There are areas of, the brain has parcels of functions. Each function, each parcel in the brain has its function. The higher level, we call it hypothalamus, which secretes some hormones which will act on the anterior pituitary, another level of the brain. And that anterior pituitary will secrete two important hormones related to menses, namely the FSH and the LH. Initially, at the beginning, it's the FSH which will be secreted, which will go then at the level of the ovaries to stimulate folliculogenesis, meaning the formation of the eggs. And during that process of folliculogenesis, that's when we get to have the production of estrogen. Estrogen then will start rising from the follicles which are stimulated. We call them granulosa cells. Then it will go to the endometrium. Endometrium is basically the inner lining of the endometrium, of the uterus. Then it will start proliferating, start growing under the influence of estrogen. And then eventually, if we take a cycle of 28 days, by mid-cycle, around 14th day, ovulation will take place, meaning an egg will be released. Once the egg is released, that's what we call ovulation. Then the granulosa cells which are left behind where the egg was growing will start secreting progesterone. Progesterone will start preparing that endometrium to receive a fertilized egg, to make it sponge-like. That's the function of the progesterone. And a egg which has been released can live only for about 12 hours. After that, it will die. If fertilization didn't take place, it dies. Then eventually, 7 days later, the progesterone which is being secreted by the corpus luteum then will reach its peak. And then if there is no implantation because the egg was not fertilized, then it will start dropping. As it's dropping, then there is no support on the endometrium. Then the shading of the endometrium 7 days later will take place, and then that's what we call menstruation. By then, why does it happen that they stop menstruating? It's just because of the fact that women are born with a set number of eggs, unlike a man. A man will continue producing his egg till he dies. But a woman, she's born with a number of sets of eggs which deplete as she's menstruating. There will be a moment where those the reserve of the eggs get to be finished, and then they menopause. When does it finish? It varies from person to person. But studies have shown those studies they were done in Europe, in European, that majority of women, they menopause around 51 years of age.
Oh, okay.
But naturally, as early as 40, or we can say the range is between 40 and 55 years of age, but
Yeah.
majority around 51 years of age. Then they would deplete their eggs, then they don't produce estrogen anymore, then they go into menopause. However, there are other causes of menopause which can be there, immunological causes, iatrogenic causes, meaning when we are operating on patients especially with cancers, when you are operating on them, you may be forced to remove the uterus and the eggs. In such a case, then you bring the patient into surgical menopause, iatrogenic menopause. But eggs, usually the ovaries, we don't just remove them, we remove them only if there is a reason.
Yeah.
If let's say a person has fibroid,
Okay.
and they are traveling her, she can't go on with her life, there are many complications related to fibroid. For that reason, then you want to remove that uterus, you don't remove the ovaries. Because if you remove the ovaries, then you castrate this person. You push her into menopause. And estrogen is very, very important for the life of the woman. To continue, we will see it later as we are talking. It's very important. Even if later they've reached menopause, you operate on a woman who is maybe who's menopausal, who ceases to menstruate. For benign causes, you operate to remove, let's say, the uterus. You leave that ovary, even though it doesn't have follicles, it still produces hormones which are important for life, like androgens. Some of it will be transformed into estrogen, and then in the periphery, it's important. Now, we have spoken about menopause, what brings it about, and what are the effects of lack of estrogen. The main problem in menopause is lack of estrogen. Is the estrogen which brings about many changes.
Okay.
Once the estrogen has been taken away, then they start experiencing a big range of changes in their lives. They become irritable, women. They become irritable.
Yeah, they get angry.
Easily.
Every now and then,
They have mood swings.
Yes.
But I guess the biggest one would be related to changes in the genitourinary tract, vulvovaginal system.
Yes.
When we have in the genitourinary tract, it leads to atrophy of the genital tract. And that atrophy leads, the lack of estrogen thereof, leads to the thinning of the tissue and narrowing of the genital tract. That then will lead to difficulty in getting intimate, because they get dry. With that, intimacy becomes painful. They are no longer enjoying intimacy. Then that will have a repercussion on their lives. They can't again really enjoy things they were enjoying. They become irritable. Besides that, we can explain the mood swings, the depression, and all of that kind of related to that. But that is not the only thing. With the decrease of estrogen, they tend also to have what we call vasomotor symptoms. Vasomotor symptoms is basically the blood vessels. They dilate, the temperature goes up, they start sweating, what we call hot flashes. And then after that, they will be sweating. Everyone is fine. It's winter, but they are sweating. And that gets again to irritate them. That again can explain the anxiety which they experience. Why do they develop vasomotor symptoms? It's basically again related to the estrogen, but there are other theories which are used to try and explain the reason.
Okay.
In every individual, including men, there is what we call the thermoregulator in the body. It's situated in the hypothalamus, a section of the brain. That way it's situated. There is a set level, the upper limit, beyond which the person will cool down. If you go beyond that, they will start experiencing like heat. The body will regulate itself to start cooling down.
Yes.
And a lower limit below which the body will start shivering so that they increase the body temperature.
Okay.
That's natural. It happens like that. But then in people who experience vasomotor symptoms, it is said that their thermoregulator range is very narrow.
Okay.
It's very, very small. Then a subtle change in the chemicals, there is also a certain hormone called norepinephrine, which is responsible. It has been demonstrated that they have increased level of norepinephrine. That then induces the changes in the temperature. With the hot flashes, then they will end up with sweating at night. They are frustrated. They are sweating at night. They can't sleep. Then that carries on again during the day. The next day at work, they can't perform well. They get irritable. All of that. And then on the bone, with decreased estrogen, normally the bone health, in being it in men or women, the bone gets to be transformed. We call it bone remodeling.
Okay.
There is a process, a continuous process of bone formation and bone resorption.
Yes.
That is brought about by two different types of cells. There is what we call osteoblasts.
Okay.
Those, they favor bone formation, and osteoclasts, which resorb bone. It means the bone, as it's forming, the old bone, which is aging, it will be trimmed down by osteoclast. Okay. The osteoblast, they favor bone formation. It's a continuous process to maintain the strength of the bone and all of that.
Oh, okay.
Now, with the menopause, decrease of estrogen, we have increased effect of osteoclast. Then bone resorption increases. Then the bone becomes weak. That's what we call osteoporosis.
Okay.
Yeah.
So, doctor, you spoke about a lot of things, you know, and guys, go high. I think no gonna go ahead Google. Everything we would feeling if you message or let's hear mara with or make sure you Google. So, doctor, you also spoke about. I want to take you back. You also spoke about fibroids.
Fibroid, yeah.
Fibroids, they grow inside the womb. Is that right? Is it fibroids or?
Fibroids, they are benign.
They're like eggs, right?
Not really eggs. They have different shapes. Okay. They are benign growth on the smooth muscle of the uterus, but they are mainly in the muscles of the uterus, but they can grow in the pelvic area. They can grow mainly on the uterus. They can grow in the broad ligament. They can grow on the ovary. They can grow distant. They can grow even in the areas of the abdomen.
I want to understand what causes that.
Fibroid.
Yes.
Fibroid, truly speaking, we don't know what causes fibroid. Okay. However, studies have shown that patients they are very common in black people. Yeah. Patients who don't have kids, who have never been pregnant, they tend to have fibroid. Patients with less number of kids tend to have fibroid. Importantly, also, patients who have relatives who have fibroid, they tend to have fibroid. That tells us that there is a genetic predisposition, a link. But then, unfortunately, so far, that gene hasn't been found to say this is the gene responsible for fibroid. And then we have the effect of estrogen. It has been demonstrated that fibroid, they are common in reproductive age. That's where they grow, they thrive, they become big. Especially even when, let's say, a person who has fibroids, they can still be pregnant. When they are pregnant, the fibroids, they grow very big during pregnancy. Then that tells us that these are hormone-sensitive growth.
Okay.
But then again, to support that theory, when a person reaches menopause, they start shrinking. Then it tells us that they respond to hormones. But truly speaking, to say this is the single cause of fibroids, we don't know.
But now tell me, doctor, if a woman can be pregnant and the fibroids can also grow inside, doesn't that complicate the pregnancy? There won't be any complications.
Yeah. Thank you for the question.
Yeah.
Yes, fibroids on their own, they may lead to difficulty in conceiving, and especially depending on where they are located.
Okay.
Fibroids, they can be like on top of the uterus, we call them subserosal.
Okay.
They can be inside the muscles of the uterus, we call them intramural.
Yes.
And they can be inside the uterus, in the cavity, just below the endometrium.
Okay.
Those, they can lead to recurrent, or not really recurrent, they can lead to pregnancy losses.
Yes.
When the embryo gets implanted in the uterus, if it's implanted at the level where there is a fibroid, such pregnancy, they tend to be miscarried. Yeah. Again, they can lead. We said they can lead to difficulty in conception. If they are close to the fallopian tube, they will obstruct the fallopian tube, and then fertilization will not take place. Now, let's assume a person has fibroids, and then there is implantation in the right place. That pregnancy continues.
Yes.
We said that they respond to hormones. They will grow very fast, and that person will be in severe, constant pain till the time of delivery.
Okay.
Constant pain. The pain also is brought about as they grow big, they outgrow the blood supply in the center of the fibroid. Not blood, enough blood will reach to supply the nutrients, and then it will die. That's what we call red degeneration.
Okay.
Then that again leads to severe pain. Now, the time they go into labor, it has also again impact. Okay, first of all, because of the fibroid, they grow big.
Yes.
Then the baby does not have enough capacity, room to grow. Then if they did not miscarry, they may end up with preterm delivery.
Okay.
Because of accommodation problem.
Yes.
Preterm delivery, yes, they go, maybe they reach, they get to term. When they go into labor, the conduction of impulse during the contraction of labor start from the fundus, the top of the uterus, and then they filter toward the cervix. Now, with the presence of fibroid, that conduction is not smooth or coordinated as it should. Then you have, or you end up with uterine inertia, a uterus which is not contracting in a coordinated way. Then that's leading to either slow progress or labor which is not progressing because the uterus is not contracting properly. Then you may end up now doing a cesarean section. Cesarean section, again, it depends. Where is the fibroid located? If it's located in the lower segment, it would be better if it's posteriorly. That's fine. It's not going to affect you. But if it's in the anterior aspect, then it becomes a serious problem. You must avoid to cut through the fibroids when you're doing a cesarean section because they bleed excessively, and that can lead to serious complication.
So now, doctor, if it keeps on growing every now and then, doesn't that pushes you as a doctor to remove the womb?
Yes, fibroids, they are very common. As we said, you know, today with this lifestyle we are having, most ladies, they are no longer like our parents who started having kids at a younger age because they go to school, they have to go. You speak to many women, they will tell you, no, I want first to get a job, I want to be financially secured. Then we are seeing a trend where women start their reproductive career late in life, around 30 plus. And that time already they have fibroids. Now, yes. A person who doesn't have children, you are not going just to remove the womb for that person. They're going to say you are cruel. There are many modalities which we can use to deal with fibroids. But then for a person who doesn't have kids, the appropriate one would be myomectomy, meaning you operate, you go just remove the fibroid. But for people who have finished having kids, well, then you can offer removal of the whole. There are other methods which you can use, but the permanent one where you are certain that you have done it and it's not going to cause any trouble, it's a hysterectomy. But there are other modalities which you can use, which sometimes don't work well. Fibroids still come back.
All right, doctor. I have a few questions for you here from our social media platforms. So we'll be asking you those questions, and hopefully you'll have the answers for the people who sent the questions. And maybe to someone who's watching now, maybe who also has a question, at least you'll be able to answer those questions, doctor. Let's drink water. We'll come back. Guys, we're coming back. I'm enjoying this. Welcome back, guys. This is Connekt Media, and we're still chilling with the handsome doctor here. All right. As I said, doctor, we have questions. And I think some of these questions, before they even asked, you answered them, you know. But I will ask anyway so that you can maybe simplify the answers for them.
Okay, that's fine.
All right. We have Karabo Are. Could you explain what exactly estrogen is and how it relates to menopause?
Okay. As we said, estrogen is a mainly female hormone.
Okay.
Which is secreted during as we explained, during the follicular phase of the menstrual cycle.
Yes.
When a person is born, they are born with a certain number of eggs.
Yes.
And then from the prepubertal moment, that's when then they start, when they get into puberty, the hormones start being secreted, the estrogen starts secreting in great quantity. Then the differentiation between the shape of a man and a woman start taking place. It's because of the estrogen. And with that, then you start seeing the deposit of fat in the hips, unlike men. And then eventually in menopause, that hormone gets to be taken away. When it's taken away, then you have all these consequences, like the genital tract atrophy, the genital tract becoming atrophied, meaning becoming thin. The tissues, they are becoming thin, which leads then to decreased secretion of lubricant in the genital tract, leading to what we call dyspareunia, difficulty in or pain during intimacy. Then makes intimacy becomes a nightmare than an enjoyable act. Beside that, we have the effect of estrogen on the bones, where then with that, when the estrogen is decreased, there is no stimulation of what we call osteoblast. Then the bone resorption becomes higher, then the bone gets thin, and that can lead to fractures, lead to fractures of the vertebra, of the hips, and also of the wrist. A person can just be walking, trips and falls, and breaks the bone. Estrogen depletion has also some effect on, if we look at it, we have talked about the mood swings, all of that. Then it can also lead to vasomotor symptoms, which we've spoken about, the hot flashes, which Should I again repeat, go through it? Vasomotor symptoms, basically they experience the hot flashes.
Yeah.
We said vasomotor symptoms are mediated by chemicals, the neurotransmitters like norepinephrine,
Yes.
but estrogen is also implicated. When it's decreased, then they have that. With vasomotor symptoms, they have the hot flashes. When they happen at night, we call them night sweats,
Yes.
and then they won't sleep properly. Then the next day, they did not rest properly. Then they become irritable, and that leads to anxiety and all array of implications here.
Doctor, you must also consider being a teacher. You must just add it on your qualifications. You must think about it. You're doing it very well.
We teach also.
Oh, you teach also?
Yeah, we teach
Yeah, no,
students.
you're a good teacher, doctor. Yeah, you're a good teacher. Okay, this one, yeah, no, it's funny. We at Butsilo, and this question is from Butsilo.
Okay.
Yeah, her name is Butsilo. Butsilo says, are there natural remedies that can help with hot flashes, or do I need medical intervention?
Yeah. The best treatment for hot flashes is estrogen.
Okay.
Yeah. Now, that is the best, clinically proven. It's estrogen. But then there are other medications like plant like phytoestrogen and others, soyas, which they claim that they do
Yes.
alleviate the symptoms of lack of estrogen or hot flashes. But then studies which have been done, the randomized controlled trial, where they take patients, they give them the medication,
Yes.
and others they give them some, we can call it water, and then they don't know when they are receiving. And when they compare, they show that estrogen is superior to these other medications which they give. By the way, when you are giving estrogen, again, it's important to check, is your patient having an uterus? If the patient is having uterus, we don't just give estrogen. We must give estrogen and progesterone. Remember when we spoke about the menstrual cycle, we talked about the estrogen and progesterone, which was secreted by the corpus luteum. Now, if you give them only estrogen,
Yes.
you will stimulate the endometrium, and that can predispose patients to cancer of the endometrium. Therefore, it's important you give them progesterone also. The only case where you can use estrogen alone, it's when you are using a vaginal estrogen. That is in small amount. It does not really affect the whole system. It's not going to affect the endometrium. Hence, you can use it unopposed. You can give it alone. But
Yes.
when you give it systematically, when they are drinking it, it must be estrogen and progesterone. Yeah. But then again, there are other issues related to that. Okay.
Yeah, doctor, yeah, no, I must say, women go through a lot.
Yeah.
Yeah. Leboha modimo hore o monna ngwana wa hae. Okay, next question is from Ntlantla. I've been having trouble sleeping at night. Could this be related to menopause and hormonal changes?
Okay. How old is Ntlantla?
I'm not sure.
Okay, she's asking, she's saying that could it be related to menopause? Then we assume she's menopausal. She has
she's
stopped
over
menstruating.
40, I guess, yeah.
Not just the age. Remember, not
Oh.
everyone at 40 would have. You can go up to 55 still having your period, as we said.
Really?
Yeah, and as long as you're having your period, you are not yet menopausal. Yeah. Okay, yeah, it could be, but it's important also to exclude other reasons which can lead to insomnia, inability to sleep.
Yes.
Yeah. Because we shouldn't blame everything on menopause.
Yeah.
Yeah. It's important. Most often people don't sleep because there is a problem. Try to find out and rule out all other causes of insomnia, of inability to sleep. If you haven't, there isn't, and then you are menopausal, then we would say. And one of the symptoms which would suggest or pathognomonic saying if once you are having this symptom, you are menopausal, it's hot flashes. If she's having hot flashes and then she's having these difficulties in sleeping, then we would say yes, maybe it's related to menopause. Yeah. And when you are treating such, it's important to initiate the treatment as early as possible. When you're initiating the treatment of menopause, there is what we call the window of opportunity, meaning it should be initiated in patients before 60 years of age or within 10 years of menopause. Once they've gone beyond that, they're above 60, it has been 10 years since they've been menopausal, then the benefits of menopausal hormone therapy becomes lesser.
All right, no, doctor, no, I hear you. Guys, I hope you're recording or you have a pen and a piece of paper or your diary with you so that you can take note. And it's important when you consult to ask questions, especially if Dr. Obotsa, you have this and that. Make sure you ask questions so that you understand what's happening with your body. All right, let's go to another question. Doctor, if I don't pronounce this well, I think you'll assist me.
Okay.
We have Sbongiseni. She says, is there anything I can do now to prevent osteoporosis during menopause? Did I pronounce it well?
Yeah.
Thank you, doctor. No, I'm getting there.
Okay. By the end of this interview, you'll have your certificate.
Oh, thank you, doctor. My goodness.
Okay.
Yes.
Yes, there are different measures which can be done to prevent menopause. Osteoporosis is basically a bone weakness.
Okay.
As we said, the bone formation and bone resorption is a balanced one. Before the age of 60, it's comparable between men and around 50. From 60 or before the age of 50, it's comparable. But then when a woman becomes menopausal, it decreases by about 1% per annum. But when a woman becomes menopausal, that rate is higher. Therefore, we say estrogen has to do with that. That's how we experience. Now, what can one do to prevent or minimize the development or the progression to osteoporosis? We call it lifestyle modification. Okay. Avoid any bone toxic substances, like smoking. Smoking does lead to bone thinning. Therefore, one should not be smoking when you are menopausal. 2, increase intake of alcohol affect the bone health. Shouldn't be being done. There are medications also which lead to that, but then that will become now a balance of why is the person taking the medication. There are medication, the steroid, what we call glucocorticoid. They also for long term, not short term. When you use it for long time, but again it depends on what is the indication, and now we have to balance bone health and the reason why it's being prescribed. Can you stop it? What will be the impact on the health of the patient? Can you continue with the medication but at a lower dose? That should be a balancing act. Then there are things like exercising. Weight-bearing exercise. That stimulates the osteoblast and decreases the rate of the progression of osteoporosis. Simple things like intake of calcium. The daily calcium requirement in a woman is about, I think, 1,200 milligrams. But then sometimes with age, because calcium to be absorbed, you need vitamin D. With the lack of estrogen, the skin thickness decreases. Therefore, and sometimes here in Africa we are better because we have readily available sun, we are exposed to the sun, because vitamin D is synthesized from the skin. Unlike our fellow Europeans who do not have sun available all the time. Then that will be synthesized from the skin and then facilitate the absorption of calcium. You need vitamin D to absorb calcium. Calcium will get it from your milk, get it from a daily product, like yogurt. If that is not adequate, then you can now supplement calcium from the shop tablet, which you can take. Fish bone also is rich in calcium, but please don't go and swallow bones. Those are the measures of which one can take to try and alleviate or minimize the progression to osteoporosis. Yeah.
Okay, doctor, I think I'm left with about four questions, but we'll come back to the questions. Guys, Erona Metsi Rabo. Oh yeah? Welcome back, guys. This is Connekt Media, and we're still chilling with the doctor here. We're talking about the menopause. I know nothing about menopause, but I'm learning a lot today, and I hope, Luena, you're learning a lot. Okay, I'm continuing with the questions. Doctor, we have another question here from Malebo. Malebo is saying, how can couples navigate changes in intimacy and communication during this phase?
Okay. It is important especially for the male partner, to understand that these are inevitable changes which are taking place. It's not just that, it's not that the partner is becoming naughty or is rejecting him. Yes. Therefore, it's important for a male partner to be informed, to know that these are the things which will happen. As we said, the atrophy of the genital tract, the dryness of the genital tract. With that, then intimacy becomes painful to the woman, even to the man also. It becomes painful, not really enjoyable. But then, as we said, there are things which can be done to try and alleviate these changes. The core is estrogen. Okay. Then if there is evidence of atrophy, meaning the thinning of the inner lining of the genital tract, then estrogen becomes important. You can use topical, don't have to use systemic, because estrogen has its own drawback. Yes. In patients with cancer, breast cancer, you're not going to prescribe them estrogen. Patients with, say breast cancer, patients with risk factor for cardiovascular accidents, meaning strokes, myocardial infarction, those patients also, you're not going to prescribe them estrogen. Yes. But then in this case, you exclude all those things, then you can prescribe estrogen, only a topical one, which they can use every day at the beginning, but later on maybe twice per week. That will assist the growth of the genital tract epithelium, meaning the lining of the genital tract, and improve on the lubrication of the genital tract, and that will improve also intimacy. There are also other water-based lubricants which can be used to try and assist in that regard. But understanding first the process is very important. Yeah. Okay.
I think now we... At the end, this is the last question. Ntombi says, I've heard about herbal remedies for menopause. How do they compare to traditional medical treatment?
Yeah, okay. You see, these are herbal remedies. They are claims which are put forth that they are working. As we said, there are control randomized trials which have been done. They've shown that they are not effective as compared to estrogen. Yes. Estrogen is the best, but then you must balance the use of estrogen with the risk factors of the patient so that you don't, it shouldn't become a burden to the patient. Yes. Yeah.
Okay, no, doctor, thank you for your time. And I really learned a lot today, and I believe our viewers also learned a lot today. But before I let you go, I know we're going to come back I will be talking about something different. But before I let you go, maybe someone out there who's watching, they want to consult. Maybe they've been having problems. They didn't know what to do, where to go. They went to the clinic. They didn't get the help they needed. How do they get to you?
Okay. We are based in Buchilo Private Hospital in Soshanguve.
Yes.
We are open Monday to Saturday, but
Okay.
we don't work all the Saturdays. We work on alternate Saturdays.
Okay.
Except Tuesdays, I'm in theater. But my practice is open from 9 o'clock up to 4:30. I would say every day with the exception of Tuesday.
Okay. Doctor, thank you for your time.
You're welcome,
I think your patients are waiting for you so that you can marinate them.
Okay.
Guys, thank you so much for watching. This is Connekt Media. My name is Slyjaynext. Sabona, follow us on social media. On Connekt Media, on Instagram, or Twitter, or Facebook, or TikTok. Make sure you follow us so that you can know more. Interview make sure you follow us. Bona, Arafita. Doctor, and we still wanna learn more. Today, menopause. Next time we'll be talking about something different. Thank you for watching. Happy next time. Oh yeah?